Is your crust on? I think that's your copy. But I did call and talk to the control. And I am on teaching, so we'll see. Fail.
Is it?
All right, so far, can you all see the slides?
Yes.
All right, I'm gonna get my lecture collector going. It took off immediately, that's kind of scary. That doesn't happen very often, so I don't know. Whether to believe that or not, I guess I do that. All right, so I put something on Blackboard and asked that you all do a food journal for 24 hours. If you saw that and you did it, would you turn it in to your teacher at your site, and that day you have classes on. If you missed it, if you turn it in Tuesday, if you just do it over the weekend at your time. It was really just to give us all more insight into why we eat as much as anything else. Tonkawa, tell me maybe some reasons you might eat that don't have anything to do with being hungry.
Stress.
Stress, boredom,
Depression.
depression. Still water, anything to add to that?
Events. Social events.
Okay, because the people around you are eating basically, or just to be
Like
social?
birthday parties.
And, it includes, drinking, anything, calories too, so, right, we eat and drink socially, we eat for reasons that we're not hungry. One of the ones that I find really sort of funny, but not funny in my own behavior, is I eat when I'm not hungry, because what if I get hungry? I think, okay, well, it's 11:30 or 12, and I'm gonna have to go to class, and, it's like if I got hungry between 12:30 and 2:30, they might have to call 911, I just can't have that happening. So I eat just in case I might get hungry later. It's like being hungry is a terrible thing. It's really not that terrible a thing. But most of us sometimes we eat just because it's mealtime. So we think we're supposed to be eating. Maybe we're not really we're not hungry or bored or anything else, but it's time to eat, so I better go get something to eat. And that's just probably from our upbringing as much as anything else. Chapter 32, it's about 15 pages on eating disorders. We've got 5 learning outcomes, and the 4th one there, Enid, can someone tell me what that sentence means in your outcomes, on your outcomes page?
Apply the nursing process to each of the care for the clients for each of the eating disorders.
Okay.
So assessment, interventions, evaluation, planning.
Okay, there's 2 P's there. What are those 2 P's?
Problems.
Problem. One person said problems and one person said planning, so that's true. I just noticed, I just started grading critical thinking assignments recently, and I saw that people were having a little bit of trouble with objective 2 and objective 4 there. And I know Mrs. Haig taught the nursing process and foundations, but that was quite a while back, and I think we're having some trouble kind of remembering that we start with assessment, to identify their problems, kind of prioritize those problems, choose the ones we're going to work on, so that we do our planning, planning the interventions or actions that might be effective, we'll implement that plan and then evaluate it. So it's a little bit different than just addressing the patient because, by their medical diagnosis. It is not the same. So, anorexia nervosa, this is an eating disorder that affects, I think, in the United States, approximately 5% of females. It has the highest mortality rate of any psychiatric disorder. What is mortality rate? Yeah, okay. So I used to get them mixed up, mortality and morbidity. Morbidity sounded more like dying, but we're all mortals. Mortals do not live forever. Mortality has to do with death rate. The death rate the reason people die who have anorexia nervosa are for a couple of reasons. One is starvation and another one is suicide. So the starvation can take several forms of how their body breaks down, different things can happen, but it's ultimately starvation. And then the suicide rate is high as well. Nine out of 10 hospitalizations for anorexia nervosa are female, and usual onset is between the ages of 10 and 14. So that was a little surprising to me. 10 seems very young. It says on the slide calorie restrictions, very severe calorie restrictions. Someone might allocate themselves to have 2 grapes for their fruit and vegetable serving at a meal, or that might be for the whole day. It is, if we were talking about snacks, almonds and pistachios, we might eat a cupful or a half a cup. They might eat one. Very, very good at restricting and controlling how much that they consume. Very intense fear of gaining weight. One place in the book it said that some people with anorexia have said that they would rather die than be fat.
Excuse me, Mrs. Martinez. Is there any chance your student might be on?
Yes, sorry.
Okay, that's okay. Thank you. We share that same disease.
We do, don't we? We
Yeah.
definitely have that one. Okay, so very severe calorie restrictions, typically very low body weight. We'll talk about the BMI there, and an intense fear of gaining weight. So there's, on the second page of the chapter, on page 399, it separates anorexia by BMI. If the BMI is less than or equal to 17, that's considered a mild anorexia. Moderate is 16 to 16.99. And I can talk fast because it's right there on the chart. Severe, 15 to 15.99, and extreme is less than 15. So I didn't play with any numbers, but less than 15, wow, that has to be very, very low BMI.
Where is that, Ms. Martinez?
It's on page 399 in the DSM-5 criteria chart.
Okay.
So some of the objective behaviors you might see, of course, very deliberate weight loss. There are 2 different types. There are the restrictors who restrict their caloric intake very severely and also usually do extreme exercise, may exercise for hours a day. And then there are the second type, they alternate. Sometimes they're restricting, but once in a while they'll lose control and then purge. The things you might see, it's not really a behavior, but it's a sign, are the hypotension, bradycardia, hypothermia, and extremely dry skin, nails, hair. What does that remind you of? Does that bring anything to your thoughts about what physical condition they might have that goes along with that? Malnourished. It has to do with metabolism, really. Your body is trying to adapt to this very low caloric intake, so it's slowing down. So your heart's beating slower, your basic temperature is lower, you're gonna have lower blood pressure. The delayed gastric emptying is part of that slowed metabolism. That leads to less peristalsis and constipation. So a lot of these are interconnected. The refeeding syndrome has to do with when maybe this person might be hospitalized and put on a tube feeding or total parental nutrition through an IV. It has to be done cautiously because it's, strangely enough, that's the time that some people will maybe go into a cardiac arrest and have some severe electrolyte disturbances, is when they start eating. If they start too suddenly, too aggressively, that's a dangerous time. The osteoporosis has to do with malnutrition. The heart, really our hearts are big muscles, and when all of the fat in your body's gone, then you tend to have, your body's forced to break down muscle to use for fuel. So your heart can be, you basically start consuming some of that heart muscle. And weakening the heart, and that's gonna lead to arrhythmias and heart failure. So I don't know if the preoccupation with food, I'd probably put that under subjective. I'll have to look back in my book again. But it's not just a typical preoccupation with food, it's a pretty much 24/7 preoccupation with food. Very low hormone levels, when your BMI is very low. Males with anorexia have low testosterone. Females also have low hormone levels. A lot of times they have amenorrhea, which is the absence of menstruation. That may or may not be present. They might just have very light periods or periods every couple of months. Usually they have some signs of decreased, and probably do not ovulate regularly either, if they're of an age that they should be. So these are subjective behaviors. Fear of losing control. Everything kind of revolving around weight, weighing several times a day sometimes. Being depressed, feeling somewhat helpless. There's going to be some irritability, probably from that starvation. Social withdrawal, a lot of that we just said. A lot of times we eat at social outings, and people who don't want to consume calories will usually become more withdrawn from social activities because they don't want anyone to notice that they're not eating or drinking. You know, you can carry around a glass of water and tell someone that it was lemonade, but they might or might not believe you. The decreased sex drive kind of goes along with those decreased hormones. Obsessive behaviors would be a lot of times with the exercising, possibly for hours a day. And let's see, comorbidities. Comorbidities in this context had to do with often depression or a psychological OCD is another one. So there may be a personality or psychosocial problem that has to be addressed along with the anorexia nervosa itself. And then the feelings of abandonment or inadequacy. According to your textbook, it says that sometimes anorexia begins in a young woman maybe with a family crisis like a divorce. Maybe, you know, an 11-year-old who feels devastated that her father's leaving the family or her mother's moving out. They feel they have no control over that situation, feel abandoned by that parent and helpless to do anything about the divorce, and that can be the trigger for moving from just someone who watches their weight to someone who crosses over into such severe weight loss that and it becomes anorexia. So most of the time, the psychologists are interested in what was going on in life at the time that your anorexia began. You know, what was happening as well as you can remember. You know, some people fight this for years before they seek help, or at least months before their family notices how thin they've become. Get pretty clever at wearing baggy clothes and disguising their weight loss. They usually don't want other people to notice because they fear that person might start intervening and cause problems for them, what they see as problems. The restrictors also, according to our textbook, seem to come from families that are very, in which the children's behavior is very controlled and pretty rigid, inflexible type parents. Not like terrible parents, but just parents who are very controlling. So biology, PET scans have showed some changes in the limbic system of the brain that are similar to changes that they see with anxiety. So anxiety is one of those comorbidities you would expect. The antidepressants, the SSRIs, help some people with bulimia, which we'll talk about next, but have not been really very successful with either type of anorexia, the restrictive or the purging. Sociocultural, we talk about how in the United States and many other countries, thinness is kind of revered, I guess is the word. I heard about that reverently. We look at the magazines, we go to the movies, and most of the time the heroine is very slim. And so that's kind of a sociocultural thing. The family, we talked about a little bit. Cognitive, sometimes people find out that they get positive feedback when they first start dieting and become very slim. They get compliments and they like it, and then they kind of let it spin out of control. Now the psychodynamics, rather than sexual abuse or physical abuse, and those have been researched a little bit, some people think that emotional abuse, if there's any type of abuse in the background, it's more likely to be emotional. And one of the things that's talked about a lot in the literature is that people, because they're at the age of puberty, a lot of times when it starts, that these are children, if you will, who are afraid to grow up. They don't want to reach puberty. They don't want to begin dating. They don't want to think about having sexual relationships. So they don't want to show their body to look like they're becoming closer to being adults. There's no real consensus, but pretty much they do focus a lot on the family and family therapy for anorexia nervosa a lot. There are people who become anorexic later in life, and that seems to be happening more than it did 20 years ago, for example. So bulimia. Bulimia, I think it's a Latin term and it means insatiable appetite. It's a separate entity from anorexia nervosa, although they can have some overlap, and we'll talk about some of that. But people who have bulimia binge eat, and sometimes they do it, there's a scale. Mild bulimia are people who might eat a massive amount of food 1 to 3 times a week, and then they force themselves to vomit. 1 to 3 times a week is mild. Moderate would be 4 to 7 times per week. Severe, 8 to 13 times a week. And extreme would be 14 or more times per week. So that's, gosh, twice a day. And when we say eating an extreme amount of food, we're talking about several thousand calories in a setting. So a lot of times it's evening or night eating. It's secretive. People might drive to multiple grocery stores and buy food that they can eat. As soon as they get in their car, they might go from one fast food restaurant to another. So if the clerks don't notice, a lot of times eat in the car, eat very fast, just really stuff it in and continue until it hurts too much to eat anymore. And at that point, then they're going to begin purging and feel ashamed of what they just did and guilty and embarrassed by it. Sometimes when they start purging, they might use a spoon or a toothbrush or something like that to induce vomiting. A lot of people will stick their fingers down their throat, and there's something called the Russell sign, where someone might have calloused knuckles on the, maybe if they use their right index finger and their middle finger to stick down their throat, they might have calloused knuckles from hitting their teeth. Also see enlarged carotid glands and salivary glands, eroded enamel on the teeth from the acidic emesis. So over a period of time, and bulimics are often hidden for a long period of time. It might be years before they really get help or decide to get help. They can destroy their teeth. They tend to judge themselves by their weight and shape. That's similar to the anorexics, of course. They measure themselves by how much they weigh and their shape as well. The purgers can do a lot of things besides just vomiting. Often it's they might use diet pills, stimulants. They tend to have more maybe substance abuse issues, more hypokalemia from vomiting. You know, we lose a lot of potassium in our, if we have nasal NG tubes. We also lose a lot of potassium if we're vomiting. They also may take large amounts of laxatives, and you can lose a lot of potassium that way as well. So we have to watch for that. The typical age of onset is a little older. 15 to 19 was mentioned in your book as being typical. And let's see. So the objective behaviors, the binging we talked about, high calorie, high carb intake, induced vomiting. Because they do vomit so much, sometimes they develop some problems with their bowel tract, and they even get to where they will vomit when they don't intend to. They can just touch their stomach sometimes after a few years of this, just a little slight pressure, and vomit that easily. Subject to fluid and electrolyte imbalances, constipation, heart issues as well, go back to malnutrition. Some of the same things as we see with the anorexia, but the pancreatitis is only on this screen. And then The bulimic is more normal weight. Usually, when it starts, they might be a few pounds overweight, whereas the person with anorexia nervosa may have been thin to begin with, or average weight. The bulimic is usually a few pounds overweight initially. And this, as I mentioned, the laxative use, you usually don't see those things in the anorexics as much. The marker foods, and this was kind of debatable in the chapter, but it said that sometimes before they start a binge, they'll eat something like a few bites of a carrot that's bright orange or something. So that when they then they eat as many calories as they can, as much food as they can force down, and they vomit until they see that carrot, and then they think that they can stop it. And they usually believe that they can get rid of all the calories that they consume, but you really can't do that. When you force as much food as your stomach can hold, some of it's gonna move on into your small intestine, a little bit of it's gonna get digested. I mean, if you eat for a solid hour as fast as you can, some of that food's gonna be absorbed. So they cannot vomit everything that they ate, despite believing that they can. And some people might do that marker food thing, and some might not. Something I found interesting was diabulimia. It said there's a fairly substantial number of young type 1 diabetics who have eating disorders, and they were listed under the bulimics, but what they tend to do is not take their insulin so that they will lose weight, which is very dangerous, of course, and can cause fluid and electrolyte disorders and all kinds of problems, but they do it for purpose of controlling their weight. So maybe they ate a lot, they might eat a lot that's not appropriate for them to eat, with their diabetes, and then purposefully not take their insulin, knowing that will cause them, their bodies to, their sugars to go high, and they'll pee a lot, and they'll lose some weight just from fluids alone. But that's a very bad practice, and I was surprised that it was a large enough number to be mentioned. Another thing that was mentioned was ipecac syrup. And you all, I think it's been off the shelves for quite a long time. You used to be able to buy it in any pharmacy. When I became pregnant with my first child, I went and bought the How to Be a Good Mother book that everybody else bought. I think the pediatrician was a Dr. Spock or something. And you're supposed to have ipecac syrup in your house so that you could, if your child, ate rat poison or something, you could get them to drink this syrup and they would vomit it up. Now, and you could go buy it anywhere, anytime. Well, people with eating disorders used it, college students a lot of times would binge on pizza or something, and then all the girls in that dorm room, 5 or 6 or 10 would get together and swallow these little bottles of ipecac syrup and barf for a couple of hours. So they took it off the shelves and made it harder to get a hold of it because of that, when they realized it was being abused. So, okay. Where are you? The bulimia causes, we had a slide like this for anorexia. I don't think I mentioned that there was some genetic component in anorexia. There also is some genetic component. They've done twin studies with both anorexia and bulimia nervosa, and thought, children that were not raised together but were twins, and found a little bit of a correlation there. Sociocultural, I guess it's pretty much the same as anorexia nervosa, it's that desire to be thin. The families, it's a little bit different. We said that was a very structured, controlling family most often with anorexia, and it's not the case, believe me. In fact, it's kind of the opposite. They tend to have really disorganized, unstructured families without much nurturing, but really not much supervision either, kind of a chaotic family, where the children just kind of seem to be an afterthought. I mean, they weren't mistreated, they were just kind of part of the scene. Let's see, and that's about it for that slide. Let's see, there are some medications that are used, cognitive behavior training, we talked about that with some of the, mental health conditions that we've talked about in the past. It helps bulimics more successfully than people with anorexia nervosa. Now the people with anorexia tend to do better with family therapy. They benefit a little bit from cognitive behavioral training, but they seem to do better with the psychotherapy with the whole family involved. There's a medication called topiramate. It is actually an anticonvulsant, but it has an unlabeled use in bulimia and obesity. It has a side effect of anorexia, so that kind of makes sense. If one of the side effects of this medication is anorexia, then you would tend to not feel like binging, and then you would not have to purge. So that medication has shown to be somewhat effective, not extremely, but somewhat. There's also a medication called Orlistat. Some of you may have heard of it. It is a medication, it was kind of in vogue, gosh, I don't know how many years ago that was. Most of you probably were too young to remember it. But it interferes with the digestion of fats. It keeps lipase from working. So the result is that the person they can eat very fatty foods, fried foods, and then they will have very fatty, greasy diarrhea. And I remember one of my friends telling me she took this medicine, and she said, you know that really greasy chili they have at, Sonic or something? She said, well, that's what was floating on the top of this plate, that orange film. So, I hope you enjoyed that visual. I did. I was very fascinated, as a nerd. She said, yeah, you can eat anything, but you're sure going to notice it.
Just ate a chili cheese.
Oh, somebody here just ate a chili cheese cone and she's getting a little pale. So whether or not that you would choose to take that medicine or not might be hard for doctors to talk someone into better. They might start taking it and then stop taking it.
Do you have that in the slide or no?
It is in my notes, but I can probably tell you what page it's on. Topiramate is on 405, so Orlistat must be very close, probably on the same page. 405? 405, yes.
So the doctors don't want them to take that medication, or they do?
Pardon?
The doctors,
It's
they want them to take that
like
medication or not
steel,
take
it
it?
should be.
Oh, the question was, would doctors encourage someone to take that medication?
Psychiatric.
If it would help to control their bulimia, yes. I mean, it can be prescribed. It's not really, as I said, most bulimics are at a normal weight or maybe just a few pounds overweight. So if by taking this medicine, they lose a few pounds and are less inclined to binge and purge, they're gonna be healthier overall. I just said that the individual might take it and think the side effects were just too gross. The diarrhea, I think there's flatulence, you may have to look it up in your drug book, but when somebody has to pass a stool that's half, grease, I think when they have to go right now. So how are they gonna drive from here to Tulsa or Oklahoma City? I mean, I think you have to stay close to your home, so I think a lot of people it might be hard to hold down a job depending on how much you do, so, anyway. Like other medicines with unpleasant side effects, sometimes people choose not to take them. So nursing care, people with both of the types of eating disorders that we've talked about. Our care objectives with the anorexia client is to increase their weight because they're malnourished. With the person with bulimia, we want to have stabilizing weight. With anorexia, we hope to, with both, we want to reestablish some sort of normalized eating behaviors. And with both, we want increased self-esteem. Because if their self-esteem is focused completely on how they look, we want them to realize they have a lot more worth than that. People with eating disorders can be seen in any hospital unit, a psych unit, in the doctor's office, in the schools, a school nurse, and they notice someone who's becoming abnormally thin, someone in your doctor's office, you go in just for a sports physical, and they might say, gosh, you're 10 pounds thinner than you were last year, and you're 2 inches taller, what's going on here, you know? So a lot of people can pick up on these things. Somebody might be in the hospital, I don't know, to have their gallbladder out. Mr. Baird said that rapid weight loss was one reason that people have to have their gallbladders removed. And you might pick up on the fact that you never actually see this person eat. They wait till the nurses and then assistants leave the room to eat, then their food disappears. You think they ate it, they may have thrown it in the trash. You don't know, really. You might get together and go, have any of you seen so-and-so in room 310 eat? Well, her tray's empty. Well, I'm just curious. Hadn't noticed her eating. She's awfully thin, you know. So things like that can happen. The anorexic patients are, as we said earlier, much more likely to be hospitalized because they are starving. And it's a multidisciplinary approach to treat. The very first thing that they're probably going to be on a med search for, maybe even a step down or a critical care unit of some sort, depending on how unstable they are. If they're having heart, dysrhythmias, they're probably going to be on telemetry, may have tube feedings, may have TPN, as we talked about. So they may be in that part of the hospital until they're well enough to go to a psych unit. So when we talk about treatment and comorbidities, we're talking about the personality things and the anxiety and depression. And also, we have to be alert to the fact that these patients don't want a controlling person. They're going to perceive you as trying to tell them what to do, trying to tell them how to eat, and they feel like that's their prerogative to choose and control. So your approach is going to have to be to be kind and concerned and not overly controlling, and yet so it's a little bit difficult to establish a therapeutic relationship, and it may take a little while because they're probably going to view you with suspicion, and the minute you walk in the room, you're probably not going to be liked just because you're the nurse. So, and your job is maybe to weigh them or to get them to eat or to write down how much they ate. So you can't take it personally. Okay. So therapeutic communication, anticipate you may be seen as the enemy most often with anorexia, but possibly bulimia as well. They're more likely to seek help and accept help. But still, they've got some deeply engraved behaviors and you can't allow them to eat and then leave immediately to the bathroom because they're likely gonna purge. And the purging version of anorexic schools do the same thing. So you're always, they don't get to be alone, really. And people don't like that. Most of us like our alone time. There may be some manipulation. They may try to come up with some ruses to get you out of the room, to get you to pay attention to something else. But that's to be expected. So there are not any meds per se for anorexia, but you might have some anxiety meds or things like that for anxiety. But it's not exactly an anorexia med. The meds that we mentioned for bulimia, the two I mentioned for weight control, and also antidepressants. This virtual environment is where someone can sit and eat a virtual pizza. So that seems a little bit out there for me. I don't think we have that technology in our psych units and eat it, I don't know. But they can practice eating a meal and with other people, and it's a virtual meal. So anyway. The deep brain stimulation, that's really research, so we don't need to get into that. The psychotherapy, cognitive behavioral training works pretty well with bulimia. As I said, the family works better with the anorexics, but they both need therapy. Orientation to the unit, I guess. Like I said, you have to be kind and considerate to them, but keep them under very close observation. Encourage communication, as open communication as possible. Do involve the family because the family is involved in the situation, particularly the anorexia with the family therapy. Being consistent is part of the milieu for any psych situation. There are going to be art therapy and different types of therapy involved, as well as psychologists. The dietitian's going to be involved. The groups seem to work really well with eating disorders. But, in small communities, like our 3 communities, you're probably not going to have a group of anorexics, like a group of 6 in a unit in Stillwater or Tonopah, Enid. But that's where some of the online groups and Skyping comes into play. They're using the internet and to do that sort of thing for small communities, and it does work fairly well. Support groups are important too, and then there are some pharmacological assistance, as we said. So our nursing process, we need to assess our client, of course, their signs and symptoms of their disorder and what problems they have related to it, and then developing our possible interventions and outcomes that we want to reach, implementing those interventions, and then independent and dependent interventions, and then evaluation, of course. So I only have 1 P on this slide, but really, we talked about the problems right under the assessment, so. There's 2 A's.
It's AA, it's assess,
Analyze.
assessment, analysis, planning, implementation, and evaluation.
Is analysis problem identification? Mrs. Gould and I talked about this before class. We were like, okay, because I've seen it both ways. I've seen it with ADPI. Well, the ADPI has gone away. The DE has been thrown away. Yeah. So if you've seen ADPI, that's old nursing process. Our discussion is whether it's 2 A's and a P or 2 B's, 1 A and 2 B's. But it's basically the same process, either way you put it. Okay. So what about males? We haven't talked about males very much. There are about 11% of the persons with eating disorders are men. It usually starts at a very young age with boys as well, but they typically have a generalized, or I won't say typically, but frequently have generalized anxiety disorder. Often it starts with young boys who want muscle definition, they want a nice toned, buff body, and then gets out of control. So that's not that different from how it may happen with girls. So trying to figure out their dietary habits, a lot of times, you know, they may want to survive on protein drinks and things like that. But they've watched their heroes, their sports heroes, gymnasts and people who, marathoners and people who do biking competitions and gotten into some really strict dietary regimens. Sexual identity might be an issue. I know you're gonna get cut off soon. We've got one more slide on health promotion, but maybe or may not. The binge eating is binge eating disorder, BED. It's very much like bulimia, but without the purging. And this might be once a week. Someone eats properly most of the time, but about once a week, they just eat until they're sick. Generally, they are either overweight or obese. And then my last slide will refer you to the health promotion. We've got helping people learn regular eating patterns and provide them the education they need. Refer them to whatever community support-based groups are available. And then in your book, it's got on page 413, all of these web resources for eating disorders. And I will say questions until I lose you. Uncle Locke, any questions from you?
No, I don't see any here.